afternoon everyone. Myself Pinki Patel. I am presenting clinical spectrum of optic neuropathy due to indirect trauma in Tertiary Eye Care Center, Jharkhand. Introduction. Indirect traumatic optic neuropathy is an indirect injury to the optic nerve following an episode of trauma that lead to reduced vision and apparent pupillary defect. Indirect trauma is caused by the transmission of force to the optic nerve from a distant site without disruption of normal tissue structure. Indirect traumatic optic neuropathy has been hypothesized to result from shearing injury to the intracanalicular portion of the optic nerve, which can cause axonal injury or disturb the blood supply of the optic nerve. It has also been suggested that the optic nerve may swell in the optic canal after trauma, resulting in increased luminal pressure and secondary ischemic injury. Indirect traumatic optic neuropathy is seen in all cases of closed head trauma. In India, it is estimated that over 5 lakh people suffer from some of head trauma every year. Aim of the study to find out cause, visual outcome, clinical feature of indirect traumatic optic neuropathy. Material and method. Study design retrospective hospital-based observational study. Duration of the study 1 year. Sample size 20 cases associated with indirect traumatic optic neuropathy who present Department of Ophthalmology. Informed consent was obtained from each patient. Inclusion criteria: all patients who are diagnosed with indirect traumatic optic neuropathy were included. Exclusion criteria: patient diagnosed with direct trauma optic neuropathy or penetrating injury. At the time of presentation, demographic detail: age, gender, number of days of presentation after injury. Examination include best corrected visual acuity, near vision, color vision chart, extraocular movement, pupillary reaction. Anterior segment examination by slit lamp biomicroscopy. IOP was measured by Goldman applanation tonometer. Dilated fundus examination by direct or indirect ophthalmoscopy. Visual prognosis can also be estimated by using BEP, optical coherent tomography. Humphrey visual field done by visual field detect MRI, orbit and brain was done. Result: 20 patients out of which 14 male, 6 female. The median age group 12 year to 51 year. Occupation wise distribution. Most common occupation affected patients were student, followed by manual labor. The mean time of presentation after injury 16 plus minus 10 days. Cause of indirect traumatic optic neuropathy. Road traffic accident is a leading cause of traumatic optic neuropathy, followed by fall and sports injury and fight among friends. Visual acuity at presentation. PL negative 4 patient, PL positive 6 patient, 6 by 60 10 patient. Visual acuity after follow-up in indirect traumatic optic neuropathy. PL negative 4 patient, HM positive 3 patient, FC 1 meter to 5 meter 7 patient, 6 by 60 5 patient, 636 1 patient. BEP finding in indirect traumatic optic neuropathy. BEP pattern at presentation was studied almost all subjects except 4 patients. Visual field defect in seen indirect traumatic optic neuropathy. Visual field were not recordable in 15 patients and the remaining subjects saw field defects such as hemianopia, generalized reduction in sensitivity, central scotoma. Associated ocular complication of traumatic optic neuropathy. The commonly associated complication with indirect trauma was orbital fracture, out of which 2 were including brain infarct. Other common complication: angle recession and lid tear. Out of 20 patients, only 6 patients received IV methylprednisolone along with oral steroid therapy, and 14 patients were treated with topical antibiotic, topical steroid and nutritional supplement. IV methylprednisolone along with oral steroid in 1 week of trauma has shown improvement in visual acuity of greater than 3 lines in 2 out of 3 patients. Only 1 of the 4 patients who presented 1 week after injury and received IV methylprednisolone therapy has improved visual acuity better than 3 lines. Discussion. Indirect traumatic optic neuropathy is an uncommon but often devastating cause of permanent vision loss. Indirect traumatic optic neuropathy due to the non-penetrating effect of trauma. The mechanism include bony fragment trauma, optic nerve sheath hematoma, concussion injury, which occurs when trauma is imparted to the skull and transmitted into the optic nerve. Previous report from India were mainly study either the visual outcome or associated complication or treatment strategy. This is the first study which reported additional clinical features such as visual field defect, pattern BEP response along with etiology, visual outcome, associated complication in indirect traumatic optic neuropathy. Conclusion. Indirect traumatic optic neuropathy is sight-threatening condition, may common comorbidities of blunt confacial head trauma, Most of the indirect traumatic optic neuropathy are usually young male, and the main cause of traumatic optic neuropathy in RTA in Indian population presenting visual acuity of greater than 660 and recordable pattern BEP may be prognostic factor for improved visual outcome in traumatic optic neuropathy. Most of them traumatic optic neuropathy in the current study were treated with conservative treatment. However, results from current study provide insert the IV methylprednisolone along with oral steroid within a week of trauma would help to the patient recover faster with visual outcome. In the study, 3 major OCT findings were demonstrated in the out of the temporal retinal nerve fiber thinning was.
You have crossed the time.
These are my references. Thank you.
Thank you.
So, when you in your paper you mention indirect traumatic optic neuropathy. What is the aim of this? Why you label it as indirect, not only traumatic optic neuropathy? On what basis, on what background you are label it as indirect traumatic optic neuropathy?
So, head trauma.
Pardon?
Why you have labeled this as indirect traumatic optic neuropathy? What he means to say? What is the difference with direct optic neuropathy and indirect optic neuropathy?
What is the difference?
Okay, just as a competitive session, I am asking another question. What is APD and what is RAPD?
Sorry.
APD and RAPD.
Relative absent pupillary defect.
Yes, and what is APD?
Absent.
Remove the R, it becomes apparent pupillary
It's
defect.
very important in case of a rototrophic trauma, as you are mentioning indirect. So that's very important in case of a bilateral, what you will label. Most of the time, you people, judge generally resident, they are labeling as a RAPD is not a correct form. This is basically APD. And as a competitive, again, I have to ask another question. So, what is the common pathology, common etiology of it is for a traumatic optic neuropathy? Is data, as you already mentioned, direct and indirect. It is a direct trauma or it is some other else? What is the common cause, common etiology of traumatic optic neuropathy in total?
Retinal nerve fiber thinning.
Pardon?
Retinal nerve fiber. Commonest.
Nerve ischemia.
Nerve ischemia.
Why? Suppose you are telling nerve ischemia, why?
Which disease? Central retinal artery, pyelovessels. Which of the vessels?
Central retinal.